Hi, everyone. Welcome to the GHAPP MASLD and MASH Community Network. My name is Whitney Steinmetz. I'm a family nurse practitioner from Presbyterian Medical Group in Albuquerque, New Mexico. Make sure if you want to receive CME credit that you use this QR code to record your attendance. So today we're going to be talking about pharmacotherapy in MASLD and MASH. There are lots of other modules available on the GHAPP site for the other components of this, but today we're going to be focusing in on pharmacotherapy. So we have medications available now for lots of different components of this. And I think what's really important to look out on this diagram is that we want to try to think about things that are going to target the multimodal things that are happening here. So we know that we have lots of endpoints that we're trying to achieve, right? So we're trying to target obesity management, reduction of their cardiovascular risk, and liver-directed treatment. And we also know that these things, they're not approved in isolation. Really important that even when you're offering and discussing drug therapy with patients, that we're always including lifestyle, diet, and physical activity modifications in that, because all of these are always in conjunction with those things. There's some really good modules on the site specifically talking more in depth around lifestyle, but I just want to call out how really important that you're adding that into your discussion with patients. Because we know 7 to 10% weight loss, we can see resolution of MASH and MASLD in about 80% of patients. So we know it's a really powerful part of this tool. So in patients with that more advanced disease, advanced fibrosis and cirrhosis, we have to think differently about some of the things we're prescribing. We'll talk about that a little bit more. But overall, looking at this infographic, we just want to, especially in our GI practices, think about what are the things that will optimize all the things that are going on here, not just the liver-related things, but how can we more effectively target all the things that are going on with our patients. So let's start first with talking about the GLP receptor agonists and just kind of generally how they work. So they stimulate glucose-dependent insulin secretion. We know they're suppressing glucagon, which delays gastric emptying and directly acts on the hypothalamus to promote satiety and reduce our energy intake. They're analogs of an incretin hormone, and we know they're lowering blood glucose and causing weight loss, in addition to lots of other things that we're seeing in the literature that they're doing in regards to kidney disease and even in addiction medicine. So just kind of an overall overview of the mechanism of action here, but essentially what's happening is they can make pretty strong improvements in people's health, and especially in the liver-related targets that we're focusing on. So what's the role of these in our GI and hepatology practices? So let's just review the data really quickly about what this was actually doing and why it got approved. So it hasn't been specifically approved for a MASH-related indication yet, but that's likely coming down in the later parts of this year for sure. So the data suggested that semaglutide successfully met both primary histologic endpoints and patients had very significant reductions in MASH without worsening, which is really important, and significant improvements in their liver fibrosis without worsening MASH. So really important to consider this medication class in patients with metabolic-associated liver disease, and especially those that have diabetes or obesity as an indication. One thing we've certainly seen a lot is because of that gastric emptying delay, that it can increase the risk of aspiration on anesthesia. And I know in our practice, we've developed a tool for nurses who are screening patients for outpatient procedures to give them some added education about what they should do with these medications in anticipation of a scheduled GI procedure, because we know that it can have some increased risk of aspiration. What's happening on the inpatient side, which I also work in, is people don't always have the benefit of knowing when they should or shouldn't have taken their medications because they're coming in for an acute reason. And sometimes this involves a discussion between GI and anesthesia about what are the best ways that we can protect the patient from an adverse procedural event. And sometimes that means needing to intubate them for the procedure to protect their airway. So it's certainly made some changes on the procedural front for sure. So the next one we're going to talk about is vitamin E. This is for non-diabetic MASH patients without cirrhosis. And the main trial here, this is kind of a landmark study, it was the PIVENS trial, showed that vitamin E improved liver histology in non-diabetic patients with NAFLD or MAFLD. Keeping in mind, you're going to see that nomenclature change throughout a lot of these lectures because the nomenclature change is fairly new and a lot of these studies are much older, but we're talking about the same disease process here. So we know about 43% of patients showed histologic improvement, and that's telling us, not everybody responds to that. And one of the big barriers here is that you can't use this medication in patients with hypertension or diabetes. And we know that's those are two really common disease processes we see in this patient population. So you're excluding a pretty significant percentage of patients who have those concomitant diagnoses. So in 2023, the AASLD guidelines suggested that vitamin E may improve MASH in non-diabetic individuals, but ESOL do not recommend using it in MASH therapy due to the kind of limited efficacy on fibrosis and potential risks. And some of this is because we have other drugs available on the market now. I certainly don't use this in patients that I'm worried that might have an increased risk of heart failure or stroke, because it hasn't really proven to have any cardiovascular benefit. It might actually have some negative effects. So Pioglitazone, this is another option. There's been no real benefit of Pioglitazone over placebo for histologic features of MASH. However, it had some fairly significant improvements in the secondary outcome, which is for cardiovascular risk. And we know that that's also important, but I generally would not use this in patients that have a history of heart failure or cirrhosis. And most of that is because of the fairly significant increased risk of edema and volume overload, which we see so much in our cirrhosis patients already, especially those patients who are decompensated. And certainly with heart failure, you don't want to do things that are going to be increasing fluid retention and edema. And the other potential pretty significant risk here is that it can cause weight gain, which is often not something that we're looking for in this patient population, usually the opposite, right? So this is probably not something I would reach to for most patients, but there may still be that really nuanced situation in which this might be a tool that you still need to use. So this is the newer kid on the block. It's not as new anymore. It's been out for over a year now. Resmetirom or Rezdiffra received FDA approval last year in conjunction with diet and exercise for patients with non-cirrhotic metabolic associated steatosis and steatosis with moderate to advanced liver fibrosis. So that's stages F2 and F3. It's a thyroid hormone receptor beta agonist, and we're going to talk a little bit more about that on the next slide about what that means and why that has such a important effect on the liver. So it's selectively binding to that receptor in the liver. And let's talk about why that's important. So thyroid hormone has lots of different metabolic activities and lots of different systems, right? But thyroid hormone receptor beta is predominantly in the liver. So when it gets activated in hepatocytes, it's upregulating genes and fatty acid oxidation and lipid metabolism and breaks down excess liver fat, and thus decreasing inflammation. It also has this antifibrotic activity because it activates hepatic stellate cells that are responsible for collagen deposition, which is really important. And that's why that specific receptor plays a really important role in the liver. And I think this infographic really helps encapsulate that really well. So let's talk about the MAESTRO-NASH and what led to this drug being approved. So you're studying patients with biopsy-confirmed MASH with clinically significant fibrosis, and patients were randomly assigned to receive Resmetirom in 2 different doses and placebo. And they had 2 endpoints. So the 2 endpoints were seeing MASH resolution by greater than 2 points with no worsening of fibrosis, and an improvement or reduction in fibrosis by at least 1 stage without any worsening of inflammation. So diarrhea and nausea were really common side effects in patients. I see this some in my practice. Most patients tolerate it well. I'll say that. And for those that are having side effects, it usually gets better with time. And the one, benefit of, being in a GI practice is we're well versed in knowing how to manage nausea and diarrhea. And in the few patients that are having issues, especially more in the beginning, it's usually easily ameliorated with maybe a short course of an antiemetic or an antidiarrheal. But the incidence of serious events were really similar against all treatment groups, including those that were receiving placebo. So thinking about those endpoints we talked about in the beginning, so resolution of steatohepatitis was defined as a score of 0 to 1 for inflammation, 0 for ballooning, and any value for steatosis. And no worsening meant there was no increased score for ballooning, inflammation, or steatosis. So it was superior than placebo in those endpoints. And also important to know here that if patients did not get that 12-month liver biopsy, they were considered to be a non-responder. So missing that 12-month liver biopsy meant it was a non-responder, but they may have had improvement for the drug, but they had to be excluded. So what are the practical considerations here? So you want to be identifying patients with non-cirrhotic MASH. And to be honest with you, that's the really important clinical question you should be asking yourself, regardless of what medication you're thinking about as starting a patient on, or what might be the best medication for the patient sitting in front of you. It's really, really important that we exclude cirrhosis, or that we diagnose cirrhosis, right? And the reason why is because it completely changes our management when we do. So patients with cirrhosis need to have much more additional care, including hepatocellular carcinoma screening, et cetera. So important to be asking that question anyways. But once we identify those patients with F2, F3 fibrosis, that might be a patient that would be in consideration for Resmetirom in conjunction with diet and exercise. And I know I talked about that in the first slide, really important to include that in your education. So as far as the drug-to-drug interactions, this might look like a little bit of a overwhelming slide. And I know, whenever we're talking about medications, no one is remembering all these things. And it's important to kind of think about that, look it up before you give it as you're getting comfortable prescribing a new medication. It's really nice. The electronic medical record often will send alerts that there might be an interaction here. But the few things I would call out here, because they're really common in this patient population, is the first is clopidogrel. So you can still give patients resmetirom, but you're going to want to dose adjust. And then the other thing I would call out here is statins. So all of these patients, or a lot of them, are on statins. We want them to be on statins, right? Because it has such an important cardiovascular risk benefit for them, is that you just want to consider dose adjusting when they're on resmetirom. Don't need to stop their statin. Certainly don't want to do that, but thinking about dose adjustment is really important. So what are some more practical considerations for managing patients with MASH and resmetirom? So the duration of treatment and monitoring is ongoing. There's a 54-month trial that is going on right now. We have some questions about whether we'll need to restage using the non-invasive tests that are available, or the ones that you use to get to your initial values. And they're working on what is a more specific guideline. I will say that the AASLD already has some practice guidelines from 2024 for monitoring and safety, where they recommend that you're monitoring for safety at the 3-month mark, the 6-month mark, and the 12-month mark, and doing kind of a response assessment at month 12. So essentially, using non-invasive tools to determine whether the patient should continue on the medication or stop the medication. So we know that if their non-invasive testing score shows a consistently elevated ALT, it might be reasonable to stop the medication. If they've had an improvement in their KPOS scores, or their VCTE scores by greater than 25%, or their MRE by greater than 20% over baseline, and normalization or improvement of their ALT, then you probably want to continue the medication. But as far as how long we should continue it, those things are ongoing. So these practical considerations, and these remain true for any sort of new medication on the market, right? Is it really is dependent on insurance coverage. So we have the guidelines, we have what we think might be best for patients, but at the end of the day, patient preference and willingness to be on a medication in addition to what their insurance is going to allow them to do financially and what's financially feasible plays a really important role in that. The other question is about, how often should we be repeating lab tests and staging them once they're on the medication? I talked a little bit. There are some preliminary, certainly guidelines available now that help guide this, but as far as how long they should continue it and when to discontinue is important. And I think those questions are going to be really vital, and because a lot of patients ask all the time, is this a medication that I need to take for the rest of my life? And I think it's hard to know at this point. Certainly, I tell them for the near future you're going to be taking it, but as far as whether it's going to be for life, the data is still ongoing. And we also know that we have multiple other agents in clinical trials, and we're likely going to have more options in the near future, really, likely at the end of 2025 for sure. We expect there to be more things available, which is a nice way of, expanding the conversation that we're having with patients about what's available and based on their preference and their whole disease profile. So if you have any other questions, thank you so much for tuning in. Please visit the GHAPP MASH Community Network to view more disease state education and look if you have any more questions specifically about Resmetirom. There's more information available on the site. Thank you so much for tuning in.